This video is about some new guidance for supporting doctors who undertake a low volume of NHS general practice clinical work. This guidance was developed by NHS England responsible officers together with the Royal College of GPs, the BMA and the GMC. There is also a sister document produced by the Royal College of GPs which looks at this area in respect of all clinical work rather than just NHS clinical work. The area of low volume of clinical work has been problematic for some time. There is discussion about how much is enough, who should decide, are there other factors which matter, how do we decide, can we manage this problem better, and how can we safely retain these doctors? There has until recently been quite a quantitative approach to low volume work, with doctors being considered to be either working safely at a certain level or unsafely. The guidance involves a change from a quantitative to a qualitative approach that includes a range of factors, and these are overlap between the GP role and other roles, the breadth of the GP role, integration, benchmarking and access to peer support, the personal approach to risk management of that doctor, their approach to CPD, the duration of low volume work and how evenly it's spread throughout the year, and how much experience that GP has already. These factors are all captured in the structured reflective template, which becomes part of the appraisal discussion. So a doctor working less than 40 sessions a year will complete a template about their low volume work to discuss at their appraisal, and out of this discussion there may be some actions that arise which are incorporated in the PDP. The SRT is then reviewed along with all the other appraisal documentation by the RO, who takes into consideration the insight of the doctor, their engagement in the appraisal process, and considers whether sufficient mitigation of risk factors has occurred. The result may be that the doctor continues to practice with no changes, or that the doctor is signposted to access additional support from Health Education England, learning groups, chambers, clinical networks, accesses mentorship, or is signposted to specific schemes such as the Retained Doctor Scheme or Career Plus initiatives. If there is a higher level of concern, the RO may wish to have a one-to-one discussion with the doctor, to which an LMC representative can be invited, and this is a supportive discussion with the potential to give advice to the doctor, out of which the same conclusion may arise, which is that the doctor can continue to practice with either no changes or some additional support. Another outcome of this discussion is that the doctor may be advised to withdraw from the medical performers list, or may choose to do so. For most doctors, they will continue to engage in the routine appraisal and revalidation process and may continue to work low volumes of clinical work, but with adequate support and mitigation identified. The guidance describes in detail some potential examples of low risk and high risk situations, and this is a very brief summary. So in the higher risk area, this might include doing a role where there's very little overlap with general practice, being very inexperienced and doing low volume work for a longer period with long breaks, having CPD which is dominated by your other portfolios, having infrequent or rare inclusion in workplace-based meetings and contact with your organisation only for complaints or SEAs, being disconnected from cascades, frequent moves with inadequate efforts to ensure familiarisation with protocols and systems, working in isolation, no on-site peer contact, and being unable to source authoritative answers to clinical queries and relying primarily on immediate peer advice and supervision. Ways to mitigate against these risks include having a significant overlap between your GP role and your other role. If you're experienced and doing low volume of work for a shorter duration of time with no large breaks. If your CPD is robust and extensive, that may mitigate against the low volume of work. You may benefit from vicarious exposure to other clinical cases via peers and peer discussions in learning groups, either face-to-face, online or via social media. You may be careful in making sure that when you return to an extended scope of practice, you have a clear plan to upskill in the areas that you're less used to using. You may use your CPD to make up for the restricted scope of practice that you do. You may also have a systematic approach to induction and requesting feedback, and benefit from formal benchmarking of your practice by inclusion in regular team meetings. You may benefit from individual benchmarking of your data from your organisation, and you may also have ready access to on-site prompt advice from peers. The structured reflective template brings all these relevant risk factors into the discussion at the appraisal and allows the construction of a relevant PDP that can mitigate against some of these risks. So this process aims to facilitate reflection and insight by the GP and thus help them demonstrate that they are safe and mitigating against risks. It should improve the potential for the appraisal to support the doctor and ensure early support for the doctor from the appraiser and the RO. This should allow the doctor to retain their skills and to flourish, and to be retained safely in the workforce. Links to the guidance currently can be accessed via these two BMA blogs, or the RCGP guidance can be accessed directly via the third link on this page. Please send any feedback about this presentation to me at this email address. Thank you.